Without further ado, I'm going to just kind of go straight into the meat of this, because you don't want to hear about me, and you certainly don't want to hear about London's travel chaos. Instead, I'm going to move straight into, we've got an interesting start here, Faye. Are you all right with this? I mean, you're getting this going. You know, you're the launch, the platform to get this whole thing springboarded forward. No pressure. So we're going to have Fay Johnstone. And Fay is, let me get this absolutely right. Where have I got this? Hang on. I knew it was here somewhere. Anyway, it's Fay Johnstone, everybody, and she's rather fabulous and works for an NHS trust, I think. Is that right? Maidstone and Tunbridge Wells NHS. This is going so well, isn't it? Seamless so far, everybody. Anybody think I didn't really know what I was doing? We're going to be talking about technology called Luscii, as I understand it, and Fay's going to be supported by Chris Malone, who's the managing director of Luscii. And this is all around, this is fantastic, this is all about remote monitoring technology for virtual wards, I believe, which Fay has pioneered. And the great thing about pioneers, ladies and gentlemen, is of course they're the only people prepared to receive arrows in the front as well as in the back. So the world needs pioneers, and there is none better than the one and only Fay Johnstone. Fay, pop up. Come and tell us all about it.
Thank you.
Can you manage?
I can. Okay. Thank you. Hello. So, my name's Fay. I am the Hospital Avoidance Leader and Virtual Ward Matron of Maidstone and Tunbridge Wells Hospital. This one is slightly different because this is an acute virtual ward. So I thought I'd go into the presentation with a bit of a heartfelt journey, and this kind of identified for me the reason why I'm doing what I'm doing. So there was a gentleman in his 30s, he was under haematology. The usual length of stay for patients in haematology is quite extensive, usually 4 to 6 weeks, if not longer. He was receiving active treatment for his condition, but he knew that he was going to be very limited in regards to how much time he had left. And his drive was that he wanted to see his daughter's second birthday. He was threatening to self-discharge at this point, so haematology reached out to us and asked what we could do to support him so that he could basically still be monitored, because he was at that time receiving active treatment, but be at home with his daughter. So we went and had a conversation with him, explained to him that he would have to work with us if this was going to really make a difference, which he did. He stayed with us for a couple of weeks longer. We just monitored him at home using Luscii and our hospital in a box, which I'll explain. And he did actually manage to see his daughter's second birthday, but passed away shortly afterwards. So this is, like I said, a slightly different model, because I wanted the organisation to see the ward as a virtual ward and a real ward. So our setup is we have one general manager, they have me as the matron, we have a ward manager, band 6s and band 5s. The band 6s are the drivers really for the ward, so they will actually go and basically hunt down consultants, have discussions, and try and prise the patients out of their hands sometimes. And the band 5s are left in the hub. They are there to monitor using our Luscii system, which is a news light system, so there will be alerts that go off throughout the day in regards to observations. Because of the way that we are set up, we have quite a few pathways under us, including haematology, general medicine and respiratory pathways. So we do have special arrangements. So with haematology, for every 5 patients that are out on the virtual ward, we have a ring-fenced bed so that the patient, if they need to be transferred back into the hospital, they are seen first time by the right team. And general medicine, respiratory, any assessments that are required, they're transferred back into the SDEC, where they're seen by the right doctors and the speciality. So we started in 2022. We started off with a respiratory pathway, and we were a monitoring service in the beginning, so using Luscii, but very quickly identified that we would need treatment. So it was also working in collaboration with our community colleagues, which is KCHFT. They have a team already that can provide treatments in the community in the patient's own home. So we're working in unison with them to provide treatment. So we use our digital systems. We have 24-hour nursing care, so the hub is 24 hours a day. And we provide all our patients with a hospital in box, which includes a blood pressure machine, oximetry and thermometer. We ask them to upload their OBS at least twice a day, and we get a visual on them as well, so it's a FaceTime, just to be sure. These are our stats in October. We've actually had over 370 patients, but of course that would mess up my maths. So 350 patients, which is a saving of 2,800 bed days. So we started off with respiratory was our first one. We have general medicine under us. We have frailty, which is quite a unique pathway because they'll be able to refer into us as well. So again, bypassing ED and actually speaking to geriatricians, and our haematology pathways. So each pathway has a lead consultant. We have our own nursing team, and we work with Luscii in collaboration. Because we sit under our cooperative division, we sit under the flow, operational flow, we don't have access to any PDNs, so we were able to utilise the nurses in each area to upskill and train our nurses that were in the hub so that they would be able to give the best care. So the referral process is through our system, which is Sunrise, but like I said, our Band 6 is in reach. So what we normally do is we identify, well, I kind of identify a lead consultant and pick on him till he gives in. And then we have engagement with the nursing team as well, which is usually the specialist nurses. We then work in collaboration to look at whether it's condition specific or whether it's a general pathway. I found that with medicine, we went for a general pathway. And actually, when you look at the conditions that are there, we reviewed the data over 3 months, and there wasn't any really specific conditions to build a pathway. It was so generalised. We then, so Luscii very kindly, or CC very kindly builds the pathways for me. And then we set a go-live date with everybody in the room, and from start to finish, it should take around 2 weeks. And like I said, we do tap into the PDNs if I need to train my nurses slightly differently. So this is just a graph showing you about our activity since we started. There are a couple of peaks. The one in April to May, that was when I managed to convince one of the general medical consultants to come on board, and he was our lead consultant now for the virtual ward. So that's where you see a significant climb in April, May. And then frailty started in August, and it has continued ever since. I think November is the month where we've seen the most patients come through the virtual ward. So by implementing the virtual ward, the positive impact really, there was another patient. I had to be very conscious about clinical buy-in and safety, and I just wanted to demonstrate the case of this was a lady that was in her 50s. She was on the virtual ward with a chest infection under the respiratory pathway. She actually called the ward at 3 o'clock in the morning with chest pain, and we managed to work with the ambulance crew, got her back into ED, and our local PCI unit, which is down in Ashford, she was there receiving her treatment for MI within 2 hours. Also, the virtual ward has helped us close our escalation beds earlier than planned. It was quite a significant months in regards to when we anticipated it would be closed and actually closing the ward. We were able to support elective activity and our ED performance, and our national market. So I think we're first in the region and second nationally for our ED performance. I mean, I'm not going to put it all down to the virtual ward, but we currently have a ward's worth of patients out in the community that we're looking after. So this is a table just demonstrating our bed savings and the finances that are attached to that. This is assuming a 0 length of stay. So I kept, obviously respiratory is a lot more money than a £350, but I didn't have the figures of what the bed day, what the cost of a respiratory bed was. But as you can see, haematology is quite significant because it's a specialist bed. £770 for a night, which is a saving of £133,000. There was some missed opportunities as well, which we identified would have meant that our virtual ward would have broke even when it comes to finances. So language was a big thing in our organisation, because we had to get everybody to think of the virtual ward as an additional ward and not as a discharge. So the patients still stay under the acute, so they're still acutely unwell in their illness. We work on exclusion criteria, which is quite minimal. Basically, anybody with a NEWS of less than 5, we won't take the risk on. And approximately 10 to 15 patients need a transfer back into the acute bed for further evaluation. I had to also think about a golden hour protocol. I don't know whether you've been to Tunbridge Wells, but it's a single-bedded hospital. And the expectation for nursing staff is that we check on our patients every hour. So that's where the 60 minutes came from. And what I wanted to show was a form of escalation if we couldn't get hold of a patient, how quickly we would react to what was going on. So we have 60 minutes, and within that, there's other steps to the escalation, such as calling the next of kin, trying the patient again, and then at 60 minutes we will call local authorities for a rapid response, and we've had to do that a few times. For diagnostics, we've utilised our SDEC areas, which was quite easy because the consultant for the virtual ward is also the lead consultant for our SDEC, so getting engagement from SDEC was okay. And also we can have internal conversations with x-rays. We can plan a patient's care around their daily activity as well. We have board rounds, which is with our lead consultant, and this is once a day, where he will we'll have a discussion about what's going on with the patient. We'll give him the observations that the patient has inputted, and work out a plan moving forward, whether that's to continue further investigations needed or the patient is discharged. Again, I wanted to build the virtual ward as any acute ward in the organisation, which meant performance and our incident management mimics what is going on in the acute trust. So we're currently working with CCAM so that we can have direct communication with CCAM for any deteriorating patients. And what we found was actually clinician to clinician is an 18-minute response if needed, and also we can upgrade the patient's category with the history of the observations and a change in the condition. We can give all that information directly, which means that our patients are catered to quite swiftly. And our risk assessments are exactly the same as what you would see in hospitals. That includes falls risk assessments, Waterloo must. And what we also wanted to demonstrate here was that if the patient was transferred back into the acute trust, that the receiving ward had all the information, obviously to reduce the risk of falls is where probably I'm coming from, but so that it was a continuation of care. We did have one death on the virtual ward. It was unrelated to the admission. This was a gentleman who was reaching the end stage of his lung disease, and was at home. He'd been at home for 2 weeks. He was going to be discharged the following day. Everything looked great, and then had a cardiac event. The feedback from the family at that time was that they were just grateful that they had his last 2 weeks at home and he wasn't stuck in hospital. We've had 5 incidents reported, and that's mainly to do with communication in the early days. So again, speaking about the language, it's a transfer, not a discharge, making sure that EDNs were sent to pharmacy and not sent to the GP. We've had no PALs or complaints since the virtual ward started, and we continue to work hard. No SIs. So we do comply with our friends and family testing, and the feedback has always been good from the patients. They love the service. 95% of the patients would refer to us as good or very good. And the direct quotes have been, you know, the innovative thinking has meant that they can stay at home while they're unwell. We've had to chase a few people. They've gone to the White Cliffs of Dover to watch the aeroplanes. One guy in his 90s. And we also had somebody who was able to go to the Eurovision Song Contest while they were on the virtual ward. This is just some percentages again, patient satisfaction in regards to our friends and family feedback. They're just some quotes. So our vision is to continuously or seamlessly work with our community colleagues. So in a lot of organisations, the virtual ward appears to have started in the community. We're now looking at our community and trying to join up our working with the help of Luscii so that we have all the information that we need for our patients. Try and bypass ED, because as much as everybody thinks it's an exciting place, I've worked there, it's not. So we're trying to bypass ED and get the patient to the right place first time, and again, utilising our SDEC areas. Moving forward, these are the next people on my target list, so cardiology, paediatrics, orthopaedics, surgery and gastro. Orthopaedics went live probably about a week ago now, but there's some more work, there's some more pathways we can definitely build in orthopaedics. So that's just talking about aligning our care for our patient needs. And that's it, I think. Am I done? I'm dismissed. Okay. Back up. Hi.
And if you use that.
Yeah, hi. So thank you, Fay. That was really inspirational. And as you can see, at a time of flow, when we are currently under serious pressures, as we know in the healthcare situation, and it's all about patient flow and safety and the fact that you can actually move these patients through an integrated care system. Time and time again, we keep hearing, oh, is this ready yet? Are we ready to be doing this? Shall we have another pilot? I think we all know, and we've been to enough of these if you have, that the evidence is piling up in a positive nature. And it is time for us all to start taking a bit more action around that as leads, or we're bringing everybody together into the room to make the decision. And then people like Fay and their team can really deliver the care that they want to deliver. So I am so pleased to see these results, and I'm really pleased for you to share that with us today. And I think we should have some questions from the audience. I could take some questions from a Luscii perspective, but Fay will clearly be able to. 4. Fantastic. 4 minutes. Okay.
Thank you very much for that. The virtual wards obviously are being rolled out throughout the country. It's not just about saving bed days in hospital and costs. What I'm interested in is, have you measured, for example, rate of recovery, improvement in decompensation? In other words, they're not decompensating, so they're at home and they're moving around more. Have you measured that patient outcome more?
Okay, so measuring the decompensation of the patient. So are you measuring the outcomes from there? Because you couldn't quite hear what you're saying. So are you measuring like the long-term decompensation of frail patients, for example? Do they do better on the ward?
They do. So the oldest patient that we've had has been 103. Saw a lot of nostrils on that FaceTime. So the oldest patient we've had is 103. We haven't actively started measuring, as in what are, the decompensation of patients and what's going on. But 103 normally has an average of, I'm care of the elderly nurse by background, so normally has significant inpatient stay. He was at home, he was still doing his own thing. Our frailty pathway works slightly different in the fact that we are looking at those patients that are in care homes, so residential care and nursing homes, and instead of those patients being stuck to a bed, they're actually back in their own environment and able to do what they need to do. So we're not at the point where we've measured as such. We will do, but certainly the benefits are shown. We've seen a reduction in the number of nursing home and residential home residents throughout the organisation. We were sitting on average about 60 a week. We've managed to get that down to about 20 to 30. And what we found was having those relationships with the care homes as well.
And I think we all know the statistics as well, as if the elderly come into hospital. Every day they spend in hospital, they lose a certain percentage of muscle mass, etc. So you do the length of stay minus that time in, you can get back to the right person. Yes, please, one more.
Hi. Dimitri Varsamis from UiPath. Actually, your point about piloting is interesting. Yesterday's speaker talked about single-site implementations, which I thought was a veiled way of calling it piloting, but never mind. My question is about integration and data transfers. This was a very obvious and the main risk and issue actually faced in the early phases and stages of rolling out virtual wards. Does that still remain one of the biggest things that delay their implementation?
Yeah, great question, and absolutely it does. But we are in the very early stages. We are actually here doing serious transformation. I'll give you an example of a question. When I went to an ICS the other day and I said, they said, do you integrate? And I said, we do. What would you like me to integrate to? And I had 15 different systems and answers that came back. I said, okay, well, that's great. We have open APIs, we have Firebase, et cetera, all the protocols that should be prescribed by DTAC, et cetera. And I said, well, how long are they going to be there, these services? Which ones have you got coming next in procurement? What is going to be your long-term EPR? And then we have done integrations with various systems. One, Cerner on the cards, et cetera. But it comes down to very much what the system will look like in 5, 10 years' time and how we partner together to do that. We're built to do it, but we need the others to get on board in due course. But thank you. Thank you. That's time, everybody. But we are downstairs, so come and talk to us if you have any further questions. We'd love to understand more.
That's right. Give them a round of applause, ladies and gentlemen. Fay and Chris from Luscii Technology.